Good morning, everyone, and welcome to our monthly live broadcast session of peripheral cases from Mount Sinai Hospital, New York City. Today, it's June 19th. I, Vishal Kapoor, with my partner, Atul Kukar, here welcome you for another session. Before we take you to the lab, I hope you had a chance to attend our annual conference, the SLINK Mount Sinai Peripheral Cases Conference. We had a spectacular event with a great show, the Endovascular Fellows course to begin with on a Monday, followed by a full two-day conference focusing on both arterial and venous side. So for those who couldn't make it, unfortunately, for reasons, you can log on to our website, ccclivecases.org, and you can watch these cases, highlights, conferences, slides, and everything will be available by the end of the week. But thank you, everyone, for whoever attended. And before further ado, I'll take you to the lab. Morning, PK.
Good morning, Atul, and good morning, Vishal. Thanks so much. And it's great to see Atul joining us again. He's been such a great part of our program for the last year or so. But I want to welcome you to our team. We have Joseph America next to us, and then we're right here. He's our and all kidding aside, we tease him. His name is, how do you say your last name, Joe? Armenian. And he's been. What are you guys laughing at? Huh? My accent. And then you have Sardar Farhan, our endovascular fellow. And then you have Ray Lascano, our interventional NP and endovascular specialized. Marichu Malloy in the back, and Damien, and our wonderful AV team. And I want to congratulate everyone for a great LINK Mount Sinai. Like I said, we did 8 live cases and 4 in the venous sides, altogether 12. No, we did 16. Excuse me.
Yeah,
16 and 8. So 20. What? 16 plus 8 is what?
24.
My math. 24.
Oh,
thank
24.
you. Forgive me. It's early in the morning. So 24 live cases in 2 days. And the fellows course, we were honored to have 74 fellows who came and learned from us. But we have a fantastic case, and we've got a great presentation by Dr. Sardar. And we're gonna get to the presentation first, and then we'll get to the case. Go ahead.
So good morning, everybody. Can we go to the next slide, please? We have our patient is a female, 74-year-old. She underwent a recent diagnostic angiogram with a failed AT CTO intervention. She complains of a non-healing ulcer on the tip of her great toe. Her past medical history is the classic one with hypertension, hyperlipidemia, insulin-treated diabetes mellitus, and hypothyroidism. She's on optimal medical therapy, and we are approaching now an intervention. Next slide, please. This were the non-invasive imaging studies done for the patient. And ABI on the right side fairly low and a little bit higher on the left side. The vascular ultrasound shows severely calcified and AT and occlusion in this segment as well. So, and these were the previous angiograms, and I believe we can show better pictures today since we are already up and over with the catheter. And we can go to the next slide. So, Dr. Krishnan, shall I?
Yeah, you know what? Let's do a little bit of the case, and he has a wonderful presentation prepared. So this young lady has 2 vessel runoff. You can see that the artery in question is going to be the dorsalis pedis that really feeds that great toe. And I think part of it is the patency of the arch. Here the posterior tibia is robust, and you can see the dorsalis pedis fills up late. But again, if you look at the actual blood flow to the toe, it's only from the dorsalis pedis, which is giving those arteries because of the incomplete arch. So if you look at the rest of it, she has pretty normal arteries other than this particular artery that's occluded. She has an occluded posterior anterior tibia at the ostium, heavily calcified. And then she has no real severe stenosis of the other 2. And she's undergone a very good therapy here with our podiatry team and trying to get everything taken care of. So this has been a very stubborn lesion to heal. So we bought her, I guess, up in February, and we tried from above, and we failed. I mean, the reason we failed was all the reasons that Dr. Sardar said, where she has a heavily calcified lesion. And you can see it's a long segment AT. You can see it starts at the ostium. Now I'm going to go to the next picture here. And this picture will show you a little bit more. And it's pretty much the entire duration of the AT. Right there it kind of stops. And then you can maybe have a little island in the middle, but not really. And then you can see it's completely occluded. See, that's sort of the island I was talking to you about. Delayed cines will tell you. And right at that level where you see the taper, it really occludes. And then distally, you can see the AT coming back at the level of the ankle, really, nothing much more than that, maybe slightly longer than the ankle, but maybe the distal tibia, there it is, right there. So at this stage, when we bring these kind of patients back, I mean, we talk about it as a team, we really decide, Atul and Vishal, what we decide initially is to try to give another antegrade attempt, which we did. So what I did was, I want to show you how this looks. So what we did was we took a fielder and a teleport wire, a teleport and a fielder wire, and we knew we had a lot of dissection planes, so we went down. So we decided to go down. I want to show you how this wire looks. I wanted to just, so we got the fielder, but like I said, we got the teleport behind the fielder. Just going to pull this back a little bit. And you can see the fielder goes very good, and then right around this area, it starts to get stuck because of that occlusion like we talked about, that taper. So what I did then was I took the teleport down, and when I start pushing the teleport, Vishal, right at this area, you'll see it doesn't go. See that?
Yeah, it just
and it
goes
starts
over
to bow,
Right.
or bow, or whatever the word is. So you can see here at this stage, you know, we tried multiple times. I won't even bother. We tried multiple times, and it does not go. So what we decided to do was we decided to get pedal access. Normally with Vishal and Karthik in the room, we do ultrasound guided. Since they weren't here today, I just did angiographically guided pedal access. So we were able to get in pretty easily, and then we put our usual pedal wire, which is the micropuncture stiff.
The micropuncture.
Right? Cook micropuncture stiff wire, and then we use the dilator, and then Dr. Sardar gave us cocktails, which is similar to what? What do you
That's
give?
2.5 verapamil and 200 mics of nitro. We didn't give the heparin because the patient's already on Angiomax.
So now what we're planning on doing is wiring. And so before we start, I just want to get Atul. Is this how you would approach it, Atul?
Yes, I think you gave it a fair shot. Antegrade, you went twice. I don't know how your wire escalation techniques were the first time, but I'm sure you didn't stop with just a fielder. And this time you stopped with the fielder, knowing that the other wires didn't work. So I think this is the right way to go. You give it a fair shot, antegrade.
Well, you know, a couple of good questions for Vishal. Vishal and both of you, and also Sardar and Ray. I mean, what are your wire escalation techniques? I mean, what is your algorithm, guys? Let's start with Vishal. What would your algorithm be, Vishal, in this kind of case?
Yeah, usually like you started, we'd try to start with the hydrophilic wires to begin with to find that hibernating or microchannels, whatever you want to call it. So go antegrade like you approached with a support catheter. In this case, teleport. For people who don't know, teleport is like a fine cross catheter, a little bit more stiffer and better hydrophilic. So hydrophilic wires like a fielder or a command wire, whatever you're comfortable with. If not, if that doesn't work, then I'll start to go stiffer end wires, like more of a coronary, like a Confianza wires, to see if you can break the cap or the islands to find the channel. And if it doesn't go up, then you escalate to, I would probably go up to a V18 or a Connect 250, like the 018 systems of wires, to see if you can cross through. And I'm not that aggressive to go to an 035, but more push comes to shove, that might be the last resort. But usually if you're not reaching the 18,000, like especially the V18 wires, then you probably have to like change your approach, go the other direction, or just bring him back, or do something different, I guess.
You know, Atul, when do you decide to go pedal? I mean, how many attempts do you give? Do you go primary pedal? You know, there's a big pedal wave now. Everybody's doing pedal. You know, we aren't doing that much in Sinai. We only do it for cases like this. So I'm curious on how you approach your practice.
So I think I would take the same shot at it. I would go antegrade. I start with the Fielder XT. That's kind of my go-to wire to start with. And I would aggressively, I think Confianza is reasonable rather than going to Miracle Bro 6 or 9 in between, except the Confianza. I think before I go to V18, I'd probably go to an Estado and try to break through a cap. Yeah. And then I'd probably go to the V18. But I think if you try 2 or 3 times or 3 wires from antegrade, that's the time to go pedal.
Yeah, I mean,
some people may even start pedal, but I think an antegrade start is very reasonable. I think you would avoid some distal complications later, and if it goes smoothly, great. If not, if you can go pedal very quickly nowadays. You know, sometimes.
Well, yeah, you know, and I think that's what we want to talk a little bit about. I know that Sardar is talking a lot about CLI, but I want to just mention to our audience, you know, pedal access is great, but I think it should be appropriately used. I think, you know, with the wire skills, if you came to Link Mount Sinai, you would have seen that we, Vishal, myself, and Karthik, and our team, we crossed, you know, 2 very difficult lesions, antegrade, in 20 minutes. It was just sort of like, so what are the things you can do? Well, one is you can do the mother and child technique, right? You can use multiple. You can take the 7 French or 6 French sheath into the popliteal artery, long sheath. Then through that, you can use maybe if you want to just use a coronary guide. And then through that, use your microcatheters for support. Or what you could do is you could use a coronary guideliner. We demonstrated 2 cases of using the guideliner very, very effectively, you know, and cross these lesions, really quite difficult lesions, very quickly without using primary pedal access, which I think is very important. I think pedal access is important in these kind of lesions, but it's also important your technique. I know that our team here, both Vishal, Karthik, and Atul, have perfected the ultrasound. But you got to do what you're good at, right? If you're good at angiogram, you do angiogram. If you're good at ultrasound, you do ultrasound. Whatever it is, but you got to be good at it. That's all I really care about. You know, and the key is don't put your sheath in. We did do a case, Vishal and I did a case where we had to put a 6 French slender. Was it 4 or 6, Vishal?
It was like a 4 or 5 slender.
4 or 5 slender, I'm sorry about that. And we actually we crossed a nasty SFA, which was all the way up to the ostium of the common femoral. So pedal access is an important armamentarium. I just don't want this wave of this is my primary access to do endovascular interventions to catch on. Because I promise you that you will get caught with your pants down, and there'll be no one to pull them up. I promise you. Because you know the truth of the matter is that if you choose the wrong patient and you trash that vessel, then no surgeon's going to come and help you, especially if it's a claudican. Okay, so be very, very careful in your choice. So I just want to tell you what we do. Dr. Sardar's got a great thing. We're going to start with the fielder from distal, Vishal and Atul, and we're going to start working. I think we're going to cross very quickly because I think I'm subintimal up top, and the only question is whether we re-enter. While he's talking, please put the picture on the side, and then we'll continue. Okay? So let's go ahead. I'm just starting with the fielder. You go ahead. Don't worry about us. You got it.
Okay, you want me to do the presentation?
Yes,
okay.
absolutely.
Good. Can we have the slides on? We are talking today about patients with CLI. This is a population of around 1 to 2% of the PAD population, but the disease is defined as the presence of rest pain or tissue loss for at least 2 to 4 weeks that can be attributed to occlusive arterial disease. As you see here in this pie chart, this is a very a disease associated with a high mortality. Around 25% of those patients are have a mortality within 1 year, and 30% of them get life amputation. And the annual costs of this disease is also very high. Therefore, it's very important to address an endovascular or surgical revascularization for these patients. Next slide, please. The diagnostic approach for CLI includes the obtaining of
Give me a
good medical history and physical exam, followed by ABI and non-invasive imaging, and finally also performing a diagnostic angiogram. And the next slide is about there are certain patients who are more suitable for an endovascular approach or an surgical approach for revascularization for their CLI. Next slide. Our guidelines support an endovascular procedure. It's recommended to establish inline flow for patients with inline flow to the foot for patients with non-healing ulcers or wounds or gangrene. And it also recommends a staged procedure as a reasonable approach for these patients. And the next slide shows also a very weak, relatively weak indication, but also to revascularize according to the angiosome concept. Next slide, please.
Pull the catheter back, right?
Also, the recently published in
Pull the wire back,
2019,
right?
the appropriate use criteria, they give a high recommendation of appropriateness for performing endovascular and surgical treatment for patients with CLI.
That's good.
Next slide. Next one. With regards to obtaining access, there are, of course, you can obtain an antegrade CFA or ipsilateral or contralateral access. And next slide shows the tibiopedal access can be obtained using fluoroscopy or ultrasound technique, and should be mainly performed in the lower zone of the leg or at the foot level. Next slide, please. Next slide. Okay, patients who are suitable for obtaining tibiopedal access are, of course, those patients with advanced PAD, as in our case, a patient with CLI. Performing this access in claudicants should be matter of caution. And those patients with hostile groin or patients who are unable to lay flat for a long time are also suitable for this access. And obviously also long osteal SFA CTOs with long calcified segments are also suitable for this kind of approach. Next slide. While you obtain pedal access, there are certain things which need to be considered, like puncturing with under fluoroscopy or ultrasound guidance, use of vasodilators, as we did here in our case with verapamil and nitroglycerin, use an echogenic needle if you use the ultrasound guidance, and use a micropuncture sheath. After that, we use usually micro catheters and over-the-wire balloons, and we utilize an 018 wire strategy, or 014, as in our case here. And we perform the rendezvous between the retrograde and the antegrade access wires and catheters, and then we externalize the retrograde wire through the antegrade access. And finally, when you're done with the procedure, access site hemostasis is very important with manual compression and applying a TR band or a safeguard, as you can see here in these two images. Next slide. And with regards to the challenges for treatment of below-the-knee disease, we are obviously talking about smaller caliber vessels. The vast majority of these patients have high calcium load in these arteries. Many patients are diabetics and have vessel tortuosity. And of course, distal embolization can be a big concern for these patients. With regards to treatment options, there are several ways. There are the good old plain balloon angioplasty and drug-coated balloon angioplasty, bare metal stent, drug-eluting stent implantation, and atherectomy and atherectomy devices. With regards to drug-coated balloon, this was investigated in several trials. Some of them went positive and some of them went negative. This is a trial, the debate BTK, which showed a favorable outcome with DCB with regards to less TLR in the CLI population. And there is another study performed in Europe. The next slide, please, is the BioLux P2 trial, which was showed comparable results with plain balloon angioplasty and DCB. And finally, the impact deep in the next slide, please, showed unfortunately higher amputation rates in the DCB arm. Therefore, the trial had to be stopped, and this device is not in use for below-the-knee arteries in the United States. All these trials were summarized in the meta-analysis performed by, can you go to the next slide, please? Performed by Salvatore Cassese, and they found that the rates of target lesion revascularizations is significantly lower with the use of DCB, but there is no difference in mortality and major adverse cardiac events with the use of DCB as compared to plain balloon angioplasty. Go to the next slide. Now, with regards to scaffolding of these arteries, there are the options to implant bare metal stents or drug-eluting stents. We have three very good performed trials with first generation and second generation drug-eluting stents compared to plain balloon angioplasty, and two of them were compared to bare metal stent implantation. So in the next slide, you can see the outcomes and the lesion length in all these trials. As you can see, the lesions in Achilles trial were 25 to 27 millimeters long, and the Yukon was very long lesions, and the Destiny trial with the Xion stent had a moderate lesion length. Next slide. There was a meta-analysis performed also by the similar group as for the DCB meta-analysis. They showed that TLR instant restenosis and amputation rates are significantly lower with the use of drug-eluting stent as compared to other treatments like plain balloon angioplasty or bare metal stent implantation. And next slide, please. Next one. So with regards to finding the best treatment option, investigators usually do a network meta-analysis for this kind of decision making, and here is the meta-analysis performed by Konstantinos Katsanos,
Don't pull the
showing all the available devices and their instant restenosis rate and target lesion revascularization and limb amputation rates. And as you can see here, the lowest rate of restenosis and TLRs and amputation rates were found in the DES population. Next one. There is also a very important thing which need to be considered is the room for vessel preparation and lesion modification to reduce bailout stenting and improving clinical outcomes using atherectomy or atherectomy devices. There are plenty of them on the market, and in the next slide we see the first one is the excimer laser from Spectranetics. There were smaller studies performed with this. One of them is this one presented here in this slide. It reduced the bailout stenting rate to 45%, and success rates were 86%, and instant restenosis rate were fairly low. Next slide, please. There is also the excisional atherectomy device, Silverhawk, Turbohawk by Medtronic, and it was studied in the definitive LE trial. And if you go to the next slide, please, you see here the outcomes. The primary patency was 71%. The wound healing at 3, 6, and 12 months was 52, 61, and 72%. Limb salvage was at 12 months, 95%, and the results were also favorable for the diabetic subpopulation. And the next slide is the orbital atherectomy by CSI with a diamond bag 360. And here was a randomized trial performed with 50 patients randomized to orbital atherectomy plus POBA as compared to POBA alone. And in this trial, if you go to the next slide, it showed significant reduction of major adverse events in the patients who underwent orbital atherectomy plus plain balloon angioplasty. Next slide, please. There is also the room of debulking with rotational atherectomy. Of course, this device is more suitable for the SFA and popliteal segments and less for the below the knee arteries. There is this rotational atherectomy device, Jetstream, and the Phoenix atherectomy. The first one is from Boston Scientific, and the second one is from Volcano. If you go to the next slide, please. We have also, there is room for atherectomy using angiosculpt, and there are some studies performed with this device. And there is a newer scoring balloon. If you go to the next slide, it's the chocolate PTA. It has this certain shape, and it creates pillows and grooves, and this allows a less aggressive inflation and a lower grade of dissections of the vessel. If you go to the next slide, you see the how the inflation looks like for this scoring balloon. And there was one study, if you go to the next slide, it's actually one of the last 2 slides, I believe. This was a single arm study performed for above the knee and below the knee lesions, and as you can see here, the freedom from bailout stenting was fairly high in both segments, with 98% and 99% in above and below the knee arteries. And the mortality rates were actually very low, with 93% survival rate at 12 months in above the knee and 97% in below the knee. And this concludes my presentation, and we'll go back to the case.
Yeah, if you're talking about an overview, that was a perfect overview of what are the options for CLI with the available data. As you can see, is very, very sparse. So excellent job. So Vishal and Atul, anything to add to Dr. Sardar's presentation there?
No, I think it was very thorough. Very good job. You presented the data precisely. I think the different balloons, the different kinds of atherectomy reads down there, kind of particular choice. And I think, just like PK said earlier, the cases we're comfortable with. I'm more of a CSI guy in the below the knee, so I will predominantly go to that. I don't use the laser below, and I don't use anything that cuts the plaque really. I like the CSI. I'm also I think, more inclined to use in the coronaries. And that's why I feel more comfortable down below the knee.
Yeah, you know, what about you, Vishal? What do you like?
I mean, I agree. I mean, it's like I said, for the atherectomy standpoint of view, it's a dealer's choice, whatever you're comfortable with. I use directional atherectomy. I also use laser if it's heavily calcified and nothing would pass through, like a balloon, even a coronary balloon, then laser is my best bet to go because it really tries to just open the channel up. CSI we do use, not that often, but I guess it's the comfort level and the plaque modification which we believe in. And I totally agree with Sardar. I mean, there is dearth of data on below the knee, and we're still debating drug-eluting, non-drug-eluting, and with the recent meta-analysis, it just muddied the water even
Well,
worse.
you know, the FDA panel is today.
Right.
For the
that's what I'm saying.
SFA.
It's just muddied the water even worse. So we'll hopefully see some light at the end of the day, and hopefully we'll have some good news that will help ourselves, the patients, and some maybe technological advancements. We'll see.
So I want to show you what we did when you were away. And you can see here that what we did, again, we were hoping to put it up by the side. So we went with the fielder and the Confianza. And without much difficulty, we were able to just cross into the other crossing catheter above. Again, we had to pull the catheter back. And one of the techniques, I don't know if our AV team was able to get it on the side.
We were seeing on the side.
Oh, you were? Wonderful. Yeah. So you saw how we pulled the catheter back and then the wire went in. I hope you saw that. So the idea there is when you create a dissection channel, so sometimes you have to pull your catheter or the wire back to maintain that channel open just for a second for your distal wire to sneak into it. So once your distal wire snuck into it, myself and Dr. Joseph, we pushed a support catheter from below. And this is very important because when you're trying to externalize the wire, okay, what will happen is there's a lot of friction. So you want to get rid of that friction. So if you're able to get a support, and we use an 014 Terumo Navicross, what is it called?
Navicross.
Fine Cross, excuse me. Terumo Fine Cross here, all the way to that end. And then we were able to push the wire without much resistance all the way up. And then you can see here, we're externalizing the wire. Once we externalize it to this level, Ray Lascano just pulled out the what is it called? The sheath, or the the teleport catheter, and then we were able to then externalize the wire. Then what we did was we pushed this wire forward. We put a clip, show over here, guys. I want to show you what Dr. Joseph did. He put a clip here just to I got it. Just to hold on to this wire at this level. Can you see it? There you go. There you go. Just a forceps, and we have a forceps on the other end. Now, for the same reason that what Dr. Vishal was saying is that we know that there's a lot of calcium up top. So we're going to go with a laser on this wire. Ray is a little concerned that it may be too short, but I think with this rail we should be able to get it through. Shouldn't be much of an issue. We'll see. If we can't get it through, then what we'll do is we'll just go with a coronary balloon, balloon it, and then exchange the wire, and then go with the laser after that. But I'm worried that the balloon will not go through that segment because of the difficulty that we had with the teleport, which is a very, 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 very small wire catheter. So therefore, it really worries me a lot that it will not go through. So the key here is, if you can see what Dr. Ray Lascano is doing, is he's holding it perfectly straight. Now, the other advantage we have is I have the sheath all the way down into the SFA. So Ray should get the wire in a few minutes or a few seconds. If it's a few minutes, I need to pull out. You know?
Damien.
No?
Give me a take.
See, I'm feeling a little bit of resistance. Yep. So it's not going.
One take of them.
Let me see, Joseph.
So PK, are you? Does your, the wires go subintimal, intralumen, subintimal? How does your subintimal duration? I mean, the amount of subintimal plane you are in, does that determine what kinds of atherectomy you're going to use? Are you concerned? In SFAs you can control
Wires
a lot
right
of
there,
stuff. But in tibials, is it like more of a concern for you, or it doesn't matter?
What's that? I'm sorry, Vishal, I missed that.
No, my only question was, how the wires go subintimal and then you come back into the lumen. Does the degree of subintimal wire make a determination of what kind of atherectomy device you'll use?
Generally, yeah. I mean, people worry about doing atherectomy
right.
in a subintimal plane. I mean, we generally don't, so I'm not too worried about that.
Okay.
Is the wire with you, Ray?
No.
I just want to make sure that this comes. Okay, now he's got the wire. See, just got to be a little careful that the wire doesn't bunch up in the catheter, and then we're going to just go ahead and do the laser now. So the settings. What settings do you think, Vishal?
So start with 40.
Rail, Ray? You got to rail it now. That's the key. So our setup is we have a little bit of fluid going in to allow the laser bubble to form, and the vapor bubble to form. You know, as you all know, laser works by the vapor bubble, so we need the vapor bubble to form. So we got fluid going through the sheath. You can put it through the tip as well, which Dr. Biamonino feels is the most effective, and I think he's probably the one you should listen to over me. And then we'll go ahead and do the laser as soon as I get down here. A little bit lower, Ray. Okay, ready? Ready, people? We're starting at 40-40. Very slow. I'm just gonna step back and forth on Flora here. Just want to be very, very slow with the laser. Really allow, you know, remember the penetration of the laser is very, very low. So therefore you really need to go at 1 millimeter a second, very, very slow.
This is a 0.9 laser?
Yep, and the same area where it's not going.
Yeah.
There it goes.
Yeah, that's why sometimes I
Pull
like
the wire
laser.
in.
It just pops
There you
through
go.
it and it just makes you feel better.
There you go. It popped through it finally. Now you got to rail real hard. See, the nice thing with this sort of this clothesline technique is that you're going to have a stiff rail, because you know, Dr. Joseph is railing above or below, and Ray is railing above, and right here another area here, Vishal. Yeah. Rail, please. Yeah. Yeah. Not going. Okay, let's go 60-60. So at this area, it's not going, so we might have to use a coronary balloon, but we've definitely cleared a channel,
Yeah.
nice channel. Ready? Okay, we're at 60-60. So Ray is going to keep it straight, and Dr. Sardar is going to hold the other end straight.
Yeah.
Ready? Nope. All right, walk it out. We're going to do the corner. You can just pull it out, Ray. You can just pull it right out. Mhm.
So PK, while you're switching over, what is your feeling about knowing that?
I think in this area right now, I think it is so calcified that the balloon is not, the laser is not crossing at 60-60, and I was pushing pretty hard, you know, and I think at this stage, you know, I feel that we got through the first proximal, the first cap that was very difficult. Now I think we can get a balloon down there easy, balloon this open, and then do our balloon angioplasty, and then we can talk about our final therapy. So we're going with a 20, what is this, 30?
2030.
2030 coronary balloon by whatever company, whatever companies in your lab works.
Boston.
And so what we're doing is we're going to go down.
Right? Boston.
And the beauty here is I don't have to worry about the wire because, you know, these guys have got the wire under control. And we're going to get to that level where we saw the laser didn't cross. So I forgot to tell you about our sheet choice. We went with a Cook sheet, you know, and the Cook sheet is, in our hands, works really well. Look at that. Look at that. Didn't go. Balloon, please.
What do you think about taking the overwire the balloon from the retrograde?
We might have to. Negative. Go up. I would probably go with a coronary balloon, just because I have a short wire there.
5 French, 4
6,
5
8.
slender.
10, 12, down. So what I may also do here, Atul, is demonstrate the guide liner. Get us a Godzilla, please, up. Show me a little higher, please. 10, 12.
Well, if it doesn't go, you can try a smaller caliber balloon like the 1.5 or a 1.0 to see if that helps. I mean, I know it's an extra
Go up
step,
again.
but if that helps you, then we save the, I mean, guideline is always a great choice, of course.
12, down. Go up here. So I think this is a good technique, Vishal. We showed it in the, okay,
Yes.
12, down. Is that I think that the guide liner will help here because the guide liner will be able to give us a little more support.
Definitely.
And then we'll go with another balloon. There's a lot of water here, but that's only water. Okay. Give me the guide liner.
Red
Thank
one.
you. So the guide liner is here. So we're going to go with a guide liner and drop it at the level of the AT. So if the guideliner doesn't go, say the guideliner doesn't go, and you're unable to cross from, the next one would be for you guys what? Come from the foot, right?
Yeah,
Without a
yeah.
sheath. Hold this.
I think so.
Come from a foot without a sheath, right?
I don't know how much length per chin. I mean, if you come from the foot, you have to try to use an over-the-wire balloon. I won't be comfortable using a rapid exchange. And I don't know how much length you have at the pedal axis to put an over-the-wire balloon, because you don't want to cheese grade your vessel if you're going a rapid exchange balloon, because the shaft of the balloon can actually, while it enters the lumen, it gets sheathless.
I agree, but you know, I think that, you know, this is one of those
I
things.
think it's going to work, but yeah, it's one of the thoughts to always
All
keep
right,
in
so we
mind.
have the guideliner all the way here. Now give me a new 2O balloon, please. So what this allows is, it's sort of like a sheath extension for us, you know, for the non-cardiologist or non-interventionalist in the area. It's like a sheath extension, and the sheath extension is going to allow us to be able to apply our pressure all the way down into the area without, and more importantly, the first balloon, what happened when I pushed, my shaft bent. So the shaft will not bend at this level in order to be able to get through. So we're getting the guideliner now.
PK, I'll make a comment. I think this is a great way to look at it. I used to do a lot more antegrade CFA access for my tough below the knee cases.
Right.
And I think this, you know, then that's a complicated access and a complicated hold with just more complications down the road. So I think this allows you to come retrograde from the CFA and give you the support, just like your mother-daughter technique would. And so this is great from avoiding antegrade access.
And the
of CFA.
nice thing for all of us, cardiologists, radiologists, surgeon, is it's a monorail kind of situation here, so it's very, very easy. And you know, it was well received when we did it in the symposium. And I think that you can see here, all it is just very easy for me to operate, holding everything. And you can show me a little higher, guys, here. So we can show the balloon come out. See, I've got no resistance. I'm flying down, right, all the way to this level. And now the guideline is supporting me. And now I'm just trying to get it through. And guess what? We're through. Look at that.
Yeah, I think it's the pushability
that
that guideliner gives you a great
Yeah,
advantage.
so you know, it's like, you know, we have to cross-pollinate. And, you know, for the vascular surgeons who watch us and the radiologists who watch some of our cases, I mean, this is the kind of situation, you know, where you learn more about wires, you learn about stents, you learn about balloons, and you know, some tools that we have in interventional cardiology, which is great. Important here is that you cannot go to 12. You cannot put a four-friend system here. Dr. Sardar taught me that, because obviously it's only going to fit coronary systems here. So 14, and I think that's very, very important that you got to understand that. Down.
I think the reason balloon didn't cross was because Joseph was holding the balloon from the back. He wanted
Go
to
up here. You know, Joseph's one of our graduating fellows. He's been a real pleasure here, and you know, he's going to practice here in the local area. He's going to be a great addition to the community. 14, 16. 18, 20. All right, down. So that was a very fibrotic lesion. That was a lesion we had a lot of trouble.
It's nice.
So now, 12, 14, 16, 20.
There it is.
Done. Go up here. 16, 18, 20. Done. And over here. 16, 18, 20. Down. And over here.
So now you don't have a lot of length on your wire, so taking a 2.530, like a 200 millimeter taper balloon will
Down.
you won't be able to get up and around. Can you dock this wire?
Oh no! I think you can definitely go around. You'll
You
see.
have enough- you have
Yeah.
enough- okay.
You'll see that as long as we keep the system straight, it'll go around. So now I'm going to ask for a 2530 210 balloon.
Yeah, because you have both ends of the wire holding, so even if the distal end is whole, you can keep pushing it, and there's no.
Right, you won't lose it.
Yeah, exactly. It's still gonna stay.
So I'm pulling out the guideliner because
2530.
because the
Yeah.
You want to
2530.
take a quick picture just to see how beautiful it looks? Or you wanna wait?
Was the guideliner?
It'll look beautiful after this balloon.
Ah, okay, fine.
All right, ready? Low mag picture, guys.
And especially after doing an atherectomy, you just want to make sure that you didn't mess up and you don't find any perforation, which is late.
DSA. Are we off sailing, guys, for the laser?
We're off sailing, yes.
Okay. Inject.
I think there's a proximal lesion somewhere. That's why.
That's a dissection from the guideliner.
Yeah, there's a lesion proximally. If you open
Yeah,
that
it'll be
up,
okay. We'll be okay.
it'll be fine.
Ready?
Here is the balloon.
2530210. ACT was what, Marichu?
Get us 30 and 325.
Well, do you have a 2.5 long Avid balloon? A long Avid balloon? System straight?
Sardar, you know that, right? If you whisper like that, we can still hear you.
I'm sorry.
No, I mean, you could be
Got it.
normal in your tone. That's what I'm trying to tell you.
Trying to be quiet.
Okay, put me on. No, it's fine. And coronary, please.
Nice.
So this is a 2.0, 2.5, 2.10, unfortunately. So we're going to go up here because we don't, you know, Medtronic doesn't make enough balloons, so we don't get enough of them. So, negative. You know, go up now. Little pressure.
It's expanding
12.
well. Yeah.
Go to 12, 14, 16,
That's a lesion or
16.
a bubble in your
18.
18.
Down. Go up again.
Yeah. 16. 18.
Down. Joseph, rail the other rail for me. Pull the other wire nice and hard. Just keep it straight, like really straight. Like pull it toward you. Okay.
One.
So see how you're just using the rail of what Joseph has given me. Go up now.
Uh, 14, 16,
18.
18.
Down. We walk it back a little bit. Get some speed here. You're holding it, Joseph?
Yes.
Show me down. Show me down, guys.
Yeah, it's going good. Yeah.
Yeah. Now go up again.
Nice.
Yeah. Post the distal cap.
Yeah, I think it's very important for the viewers to visualize. I mean, to appreciate the
18.
fact that you know you need
Down.
some antegrade visualization,
Good.
even though you might do everything pedal.
Got it.
You need that antegrade approach to give you that flexibility of getting the balloon visualization, angiogram, and all the stuff. So, I know we like to do all primary pedal, but I think it's always good to have a good
Okay,
approach
DSA?
and a good result. So,
Okay, Joseph, you can
let's
move
see
your
how
hand.
it looks now. Let's give some nitrite,
Inject.
verapamil, and take a good picture.
Yeah.
Still retrograde filling.
Yeah.
Something going on proximally.
I think there's a
So give me
proximal
a
lesion.
show me
Maybe a 3 balloon proximally.
show me above.
I think
Right
you
here?
definitely stent the proximal
Inject?
segment
Yeah.
eventually as well. So.
Yeah, I think that's what's going to happen is you're right. The entry point is where it will be. See, that same thing as the proximal lesion right there.
Dissector. Stent.
I think we just put a stent.
Did you get that spot with the 2025 balloon?
We probably did, but give me a 3.0.
Take a 3
Give me a 3.0.
60 or
3.0.
80.
We'll give a 2.5 first
2.5.
above,
Yeah.
and then we'll go with, this is a 2.5 200.
That's 2.5 200.
So we're going to go with the 3.0. 3.0 80 up top,
80.
please.
Yeah. Yeah, I think you're right. There's something proximal. Either there's the dissection plane which just flips off, which might look good after stenting probably. So I think that's what you're going to end up doing.
Okay, straight rail, please.
Just, yeah. I don't have Y yet.
That'll come.
Okay, I have it. Just a second. Okay.
Trail, please. It's stuck somewhere.
Okay.
It's stuck somewhere. Where's the top?
You
There
already
it is.
passed, I think.
Yep.
There it is.
Go up now. So let's see. Can you mag up on the top, guys, for me?
Yeah, I think where's the other end of the balloon?
A little higher. Okay, go up.
Going up.
Yeah, there's a tight lesion there.
12,
12, 14,
14,
16.
16.
Down. Go up here now.
12, 14,
Looks like it opened
16.
well.
16.
Down. A DSA. Enjoy.
It's a dissection.
Yeah, it's a little better, but yeah, you have to probably just stent the.
It's interesting, huh? All right. So, give us a 3-0 balloon now.
Okay, what do you think about using your the timing for the inflations in these cases? Do you like to do a minute inflation, a minute and a half?
Well, you
When
can
you
just
have
pull
these
it out.
long dissections where you're not sure exactly what's happening, just to really pack things up nicely.
You know, for me, I got to tell you, like for me, it's like this to me is a clear dissection. I think you can see the to and fro flow. It's either one or two things, right? You have no flow, so it's either dissection or embolization. Unlikely to be embolization because we've got our ACT that's high. So the next question is, it's a dissection, could be recoil, right? But at that site, you can see a filling defect right there. So that filling defect tells me that we probably had a spiral dissection. This balloon angioplasty will leave up for a little bit longer, but I know I'm going to have to stent this.
No, for sure. I think the thing is, the question is from where and where do you stent?
Right.
And I think if you have a better angiogram after a longer inflation, you may have a better idea of where
Stuck, guys?
Yeah, again, sorry.
where you're going to have to
Yeah.
do stuff.
It's free.
All right, so we're going to go with a.
PK, what do you think is the role of scoring balloons in these lesions?
We might be able to do it here. I mean, I think it may help, but the point is, it's just adding a lot of cost
Right.
without reimbursement. To me, I think that if this doesn't feel that this doesn't restore better flow, then I think what we should do is just go ahead and stent it.
No, I agree.
Yeah.
I'm just saying,
You know?
just generally the role of.
I mean, I would use scoring in order to prevent stenting.
Going up.
Right.
But here, I think this is going to be a
long
problem.
lesion, right? I agree.
12.
Yep, go to 12.
See, it expands very well, so I think it's more of a recoil or a dissection plane. We just close it
Right.
as soon as the balloon. You can see there wasn't much resistance while the balloon was going up. So
So we're going to leave this up for 2 minutes. So I mean, at this stage, when it comes to stenting, what are you guys thinking? I mean, let's talk a little bit about let's ask Sardar, since you've just reviewed the data, about the Lutonix the BTK trial.
This was published.
not
it was
published
not
yet,
published.
just
Was presented at Viva last year, and they had 6 months outcomes for this DCB,
Yep.
and showed favorable results with regards to less TLR and less reinterventions and primary patency.
Right.
But there were no more. There was no difference in mortality. But
the
the
mortality
study
actually
was
at
not
one
powered.
year has been better in the DCB arm than the regular arm. But my question to you guys and all of you really is like, would you, if say DCB was available at Thule, is this something that you would use in this case?
No, I think I would stent this. I think you're going to have too much trouble. You're not going to get the results you want. These are probably not unlikely to be included in these trials. I think these complex ones where you're
Right.
long segments with. I mean, this is restenosed on twice after balloon already.
I'm going to go down a little bit.
I don't think I would feel comfortable just leaving with the balloon.
Yeah, I think I agree with Atul. I mean, you need a scaffolding here, especially the proximal
Little lower,
lesion, the
guys.
way it's behaving. I don't think it's good. The patency is not going to last as much. So
No, not you, my love.
if
Go
it
up
was
here.
like good distally,
Go
you might
up.
think about just doing a DCB getting away because we know there's good luminal gain from the balloon itself. But proximally in this case, I would be hesitant leaving it purely
Breathe,
on
breathe.
a
I have
balloon
12.
angioplasty
Okay,
itself.
leave it up. So Atul, say there was no flow limitation here, would you use a DCB? Down?
Yeah, so I think I would use the DCB for the majority of the lesion, but I think I would still stent that proximal AT lesion, where you had your initial stenosis where you're having trouble getting through, and I would just
Right,
keep
go
the
up there.
stent length
Go a little
short. So the DCB would allow you not to use a lot of length in the stent. But I think
Just
that
careful,
one
breathe,
spot,
breathe,
I
and we know the
8, 10.
proximal
Leave it
portions
up.
of the vessels do well or better
Breathe well
Right.
out.
with the
With
drug-eluting
stent.
stents,
Go up again,
and
bring it
you're
up.
clearly in the proximal third of the vessel at that turn.
Yeah, I think that's a great point. It's,
Okay, down.
10.
we do have those no stent
Down.
zones in the tibial, so you just want to avoid, especially being crushed in the middle and the distal. So yeah, proximally they give you good
Show me
results,
down.
good patency, and
Going up.
Show me down.
healing of the
Awesome.
osteodiscus.
Yeah, and that's the rule of thumb I go. If it's a
Go up
proximal
now.
third of the vessel, you're
You
safe to
stent.
stent. Even the proximal, 15, 20%, you're
Breathe,
you're
breathe,
in very
huh?
good shape.
Agreed, yeah.
Okay, down. So we're just ballooning it to get the outflow going.
So this is a 3-year balloon.
Yeah.
All right.
Go up slowly there. Okay, down. Okay, let's walk it out. Show me above, guys. So we did prolonged balloon up top, and I ballooned the entire segment. So we're just going to look at this area. This will tell us everything, right? So I just took the balloon out here. Ready? Don't move, my love. DSA, please. Inject.
Mm.
Much better.
Okay. So give me now stenting wise, what would you guys do for the stent above? I'm gonna let's take one shot below here. I think we got to
So
stent that.
yeah.
Exams.
Yeah, I'll take a 3.5/38.
Okay, inject.
This looks nice and healthy vessel. So I think you're right. The problem is all more proximally.
So this is what I want to talk about a little bit, and this is a great case. If you look at that last angiogram, get a 3.5/38, and you can put it there. If you look at the last angiogram, next one, please. You can see that you have a competitive flow. You notice that the distal vessel is first negative first. That means your collateral is filling the distal vessel, and the proximal is coming down. So this is just a matter of the pressure gradients have to change. So likely the pressure gradient, because of the proximal dissection, is still high. So therefore, when you stent that proximal dissection, over a period of time, this will change.
Right.
So I don't want you to chase this and put a stent in this type of situation, because next time you bring her back for whatever angiogram and you say, listen, I want to do a check, you'll see that the flow will be through the AT into the DP. So don't chase it too much.
So now I'm planning to stent the proximal segment.
Yeah, so Sardar is going to go and stent the proximal segment.
Oh,
And then what we'll do is we'll go ahead and then after that we'll pretty much call it a day. We'll touch it up offline. But I think we hit all the points that we needed to do in a case such as this, to really talk about that. So what do I mean by touch it up, Vishal? I think what we'll do is we'll go ahead, we'll put a catheter into the vessel, we'll give copious amounts of nitride and verapamil, and then we'll go ahead and take another picture. And we'll also look at our access site, make sure there's no dissections, which again, if you don't use a sheath, the chances of there being a dissection is 0 to none. So here's the 3.5 stent going in. As all of you know, Sardar is a board certified interventional cardiologist. Yep, a little dye. And we're just going to take a little picture to make sure he likes the positioning. So you're going to pull back a little bit more, right? A little bit more. Right there. What do you think, Vishal?
A little touch more.
Touch more, he wants back. Come back a little more.
That's it.
I think I like that. Yeah? Right there, a little more. I think that's good, Vishal.
That's good. I think I like it.
Yep, let's go. We're going to go up. So what did you pick, a 3.5 or a 3.0?
Should be a 3.5.
We took a 3.5.
Yeah.
So I think the perspective here is to get a big lumen with the drug-coated stent. As Sardar went over so nicely, all the data with drug-coated stenting really shows that this is the technology for BTK. Unfortunately, we don't have lens that we need to be able to line this up. Hopefully, the good folks at Abbott will resurrect the Absorb for BTK, and hopefully we'll have another option. Just because it doesn't work in the coronaries doesn't mean it doesn't work in the lower extremities either. Push balloon and get a distal edge balloon for me. A little more. It's a little more. A little more.
Yeah.
Okay, good, right there. So we're just what we do is sort of a massage of the distal edge. Then we're gonna ask them to give lots of nitride and take one last picture, and then we'll go ahead and finish up offline. So can we get some nitride, Chuj?
It's ready.
So we're gonna walk this out, and then we're gonna give copious nitride. and then we'll take one picture. So Vishal, how do you, and actually Atul, how do you deal with the access site here distally? We didn't put a sheath. We just had a microcatheter through there. How do you deal with it?
Just good old-fashioned manual pressure.
Right. Yourself, Vishal?
I think the same thing. Just use your fingers, use a fellow seal.
We have a safeguard device here, and we have a safeguard device, and the
Sardar
armband
wants to
might,
spend
might
free
be
money.
might be working.
He's lazy. He doesn't want to work.
No.
You gave the medicine?
I'm giving him.
Oh. So what is the safeguard device? You guys, I don't know what that is.
It's here. I have it.
So why don't you give the nipride and then you explain this device. So this is the safeguard device for those of you who don't know what it is, because I didn't. Vishal, can you explain it?
Yeah, I've used a few times. It's just like an inflated balloon right there.
Flush.
So it just seals the area by inflation, so it puts
There you go.
pressure right at the spot. I mean, it's good for DP, but
can
you
show.
have to understand sometimes PT can be tricky because people who are thin, they have a essentially like a scoop or a hole, so
right.
it might not completely seal it. That's why I just like the plain old holding pressure. What about Atul?
I use the manual pressure, and the safeguard I first got oriented to here at Sinai, and
DSA?
a lot of the fellows use it for the antecubital access
Yes.
for right heart cath. And I hope I've convinced some of the fellows to change that. So now what we do is we actually put look beautiful.
Beautiful.
We actually put a 14 gauge IV into the
So
antecubital for the right heart cath now and get rid of the
So Ray, you
safeguard.
can pull this wire
Works
back
very
now?
well.
Right.
This wire back. Pull it. Mm-hmm. Pull.
That looks very good. So
And the other good thing about the fellow seal, I like the
What's
word.
that?
I'm gonna borrow it.
You can just take it out.
Is that you can compress gently
yes.
and you don't occlude flow.
Okay,
Right?
ready?
This is a tough
You can take
case.
your hand
You
off.
don't want to have your outflow compromised. So you just like we do with the radial
Hold.
axis, you want to have a patent hemostasis.
Mhm.
Yeah. That's
So
just our entry point.
That's
So
just the entry point.
Yes.
I didn't want him to get radiated, so I just had him pull the film. So now you see you have 3 vessel runoff to the foot.
Beautiful.
He's going to hold a little pressure. I'm going to have Sardar just go over this device and show how to use it.
So yeah. It's
Now
a-
this is not a promotional gig. We're just something we use. We're not getting any extra cash. I just want everybody to know that this is just something we use, and I think it's something that's useful. And Dr. Kukar, like he said, he doesn't believe in it. A lot of people don't think it's necessary. Dr.
agree.
Sardar believes it's necessary, so we use it.
It's I mean, manual pressure is also very fine, but
Let's see if Sardar changes his mind when he graduates.
I guess not. So
So
That's the key. When you once a fellow becomes an attending, then you see what really they trusted and believed in.
exactly. Nothing
I-
better than a fellow
I
seal.
trust only data,
Ah,
randomized.
I like that.
randomized controlled data. So this device is actually very easy to use.
You want to show that device? I don't know how you can show it. So I think you have to
Yeah.
come here maybe.
So
Now they're zoomed
I
out,
take
so-
I take this off,
Hold on. Yeah.
the strips, and I put a empty syringe,
Yeah,
fill it with air here, and then it just opens a balloon, and those wings are holding on the
Skin.
on the skin. Yes, exactly. So I'm gonna take now this off, deflate it completely. Okay. And do this right
So
now.
now he's going to place it on the entry site, directly on the entry site. It's
Mhm.
hard to see from the camera, but he's on the entry site. And then what he's going to do is he's going to inflate it and then tape it.
Mhm.
And then Dr. Joseph is just going to keep an eye on it. So we're going to turn off the angiobags now. Americhu will load the patient with some Plavix, and then we'll send the patient for good care of the lesion.
So what about the
And-
antiplatelet? How much
We're just,
duration?
for her, we're just going to use aspirin and Plavix for shelf. We're going to do Plavix for 6 months
Yeah, it's a
and
Zion
aspirin for
stent.
3 months because the Zion stent. And I think we'll follow her in clinic and send her to our colleagues to take care of the lesions in the great toe, and then we'll see her back. I mean, as far as surveillance, very
closer.
simple. If this wound starts to heal, then you know that it's working. If the wound is healing and then regresses back, you need to do an ultrasound. Generally, we do every 3 months ultrasound surveillance, but I think it's important to keep an eye on it. So again, we're going to sign off. I think we got an exhausted crew here. We did, like I said, a ton of live cases here for Link Mount Sinai, and today's our June live case. So I thank all of you. I thank Vishal and Atul. Thank our wonderful team here with Dr. Armenian, who was his last case, I guess, live case before he goes off into practice. We wish him well. And thanks again. We'll see you soon.
Great job.
All right, awesome. Thank you, PK, for a great show. Very good case presentation of how to access pedal, approach, strategy, thought process. Thank you, everyone, for joining us. Thank you, Atul. So our next case will be on July 24th, with starting with one of our new endovascular fellows, in addition to Sardar being there. Please do join us. For this case and any previous cases, you can go to our website, ccclivecases.org, and you can log on to the archive section and see any of our previous cases. Please do leave us any comments, concerns, questions, and we'll be more than happy to answer and interact. Hoping you have a good rest of the week and July 4th, and we'll see you next month. Till then, good night from Mount Sinai.